Hello everyone in CardioMinds channel, and today we are starting one of the new recently published guidelines, which is the guidelines on the cardiovascular management of patients undergoing non-cardiac surgery. We are trying to be focused on just fewer number of videos for this topic. That's why we are trying to make about 4 videos covering these guidelines. And today we are starting with one of the longest video in these guidelines, because we are covering here like a resume on the preoperative consultation in general for those patients undergoing non-cardiac surgery, how to deal with them. There are multiple concerns and risks regarding surgery, and that's why there is a focused guidelines for this issue. First of all, there is a bleeding risk with any surgery, varying from low to high bleeding risk. But there is also a thrombotic risk, because in cardiovascular patients taking antiplatelets or anticoagulants, there is a risk with withholding these medications to have acute coronary syndrome, up to perioperative MI, or sometimes risk of embolic complications like embolic stroke. Also, there is a hemodynamic risk, especially in those with systolic or diastolic dysfunction, with risk of pulmonary congestion up to acute heart failure, and also a risk of tachyarrhythmias like atrial fibrillation. There is a hypoxic risk, and there sometimes maybe a hypotensive or hypovolemic risk due to the fluid or blood loss or problem with the gas exchange process. And all these risks are exaggerated in patients with comorbidities like aging, metabolic disorders, autonomic dysregulation, hypertension, diabetes, chronic kidney disease, plus of course the established cardiovascular disease. That's why the surgical risk can be low, intermediate, or in some cases high surgical risk. We are covering 4 issues in our video today: the clinical risk evaluation before surgery, preoperative assessment tools that we usually use, risk reduction strategies, and the perioperative monitoring and anesthesia. Let's start with the clinical risk evaluation. The aim of this process is to reduce or prevent perioperative cardiovascular morbidity and mortality, including perioperative MI, stent thrombosis, acute heart failure, hemodynamically relevant arrhythmias, pulmonary embolism, ischemic stroke, death, and in some cases bleeding complications. And in order to achieve this aim, we need to assess the patient-related risk according to his risk factors, comorbidities, or established cardiovascular disease, and also the type of surgery or proceeding he or she is undergoing, like the risk of surgery itself, is it emergent or elective, experience of an institution in which the surgery is performed. And in order to reduce this preoperative risk, we need to have adequate preoperative risk evaluation plus proper selection of the type and timing of the procedure. In this famous diagram, we can see the surgery-related risk in relation to the patient-related risk, each one divided into low, moderate, and high risk. In most of the cases, we need to have an attention for the patient's risk and the surgery risk, but there is an increased attention needed in case of one of them is high risk or both of them are moderate risk. If one of them is high risk and the other one has moderate risk, so we need to have high attention. And in some cases, if both are high risk, so we consider postponing or avoiding the surgery. Let's start with the surgery-related risk. When we speak about surgery-related risk per se, we mean the 30-day risk of cardiovascular death, MI, and stroke, taking into account the specific surgical intervention without considering the patient's comorbidities, depending on the type of surgery, duration, urgent or elective, and the type of anesthesia and anesthetic drugs. So we have the procedures with the low surgical risk with the 30-day risk less than 1% as shown here in the table, the intermediate risk procedures from 1 to 5% like these examples, and stressing on carotid intervention in asymptomatic patient is considered to be intermediate risk, and the carotid endarterectomy per se in symptomatic patient is considered to be intermediate risk. And the high surgical risk procedures, most of them are major surgeries, including carotid artery stenting in symptomatic patients, and including as well most of the vascular surgeries and amputations. All of them are considered to be high surgical risk. Regarding the timing of surgery, we need to know that the acute procedure have a higher risk of complications than elective procedures. And so we divide the surgeries to be immediate, which need to be performed without any delay to save life or organ function, urgent, to be performed without unnecessary delay to save life, limb, or organ function, so they are less immediate than the first example, time-sensitive procedure, and in most of the cases of cancer, surgeries or carotid procedures in symptomatic patients, as here they need to be performed as soon as possible due to time-dependent risk of losing limb or organ function or increased risk of complications. And so the time window for time-sensitive surgery is variable depending on the underlying disease. And last, the elective surgery, which there is no urgency and no risk of losing limb, organ function, or risk of complications. So if we ask ourselves which factors affect the outcomes after surgery, of course, the general condition of the patient plus the stage of the acute illness and how far it has progressed. And please consider the best interest of the patient and consider the degree of urgency in order to decide whether we can wait or we need to proceed as soon as possible. What about laparoscopic procedures? Most of us consider them lower risk than open surgeries due to the advantage of less hospital stay, less tissue trauma and incisional pain, less intraoperative blood loss, better postoperative pulmonary functions, less postoperative fluid shifts due to bowel paralysis, and lower incidence of postoperative cardiac complications. However, the pneumoperitoneum performed in laparoscopic procedures increases the intra-abdominal pressure and so reducing the venous return to the heart, and so in Trendelenburg position this increases the mean arterial blood pressure, CVP, mean pulmonary artery pressure, and the pulmonary capillary pressure, which may have a deleterious effect on a cardiac patients. And so healthy individuals on controlled ventilation can tolerate pneumoperitoneum. But patients with cardiovascular disease, adult congenital heart disease, or obese patients performing bariatric surgery may have adverse consequences. Therefore, the risk in those patients is not necessarily reduced with laparoscopy, and we need to evaluate the patients in the same way for laparoscopy or open surgery. Regarding endovascular surgery, of course, it is associated with lower operative morbidity and mortality than open repair, like EVAR, for example, for abdominal aortic aneurysm. And so, in patients, for example, with peripheral arterial disease, an endovascular approach is advisable due to significant comorbidities with open surgery. And so there is a class 2A for endovascular, or in some cases video-assisted procedure like thoracoscope, to be considered for patients with high cardiovascular risk undergoing vascular or pulmonary surgery. So we finished the surgery-related risk. Let's move to the patient-related risk. In general, all patients scheduled for non-cardiac surgery should have an accurate history and a clinical examination in order to perform a preoperative risk assessment at the same time as the surgery is proposed, and if time allows, we need to optimize the guideline recommended treatment of their cardiovascular disease or risk factors before surgery. And of course, the prognostic value of this risk assessment is much higher in elective surgeries than immediate or urgent surgery. If your patient is younger than 65 years without signs, symptoms, or history of cardiovascular disease, we only advise ECG and echo before surgery if he has a family history of genetic cardiomyopathy. But if the patient between 45 to 65 years and is completely asymptomatic and no specific cardiac history, ECG and biomarkers are only advisable before high-risk surgery. Otherwise, they are not indicated, and here it is a class 2A recommendation. This interesting flowchart shows us how to manage a patient before non-cardiac surgery. If your surgery is emergent or urgent, so we need to proceed for the surgery as soon as possible, as cardiac testing here is not feasible. But if your surgery is time sensitive, so we need a multidisciplinary decision on the individualized cardiac testing. If your surgery is elective, so we have time to perform accurate history and the clinical examination, including the standard lab test, and advice on stopping smoking and to start guideline recommended medical treatment. If your patient is younger than 65 without any cardiovascular disease or risk factors, so if it is a low or intermediate risk surgery, no need for any investigation, but if it is high risk surgery and he is older than 45 years, we need to consider an ECG and biomarkers. If the patient is older than 65 years or he or she have risk factors for cardiovascular disease, if it is low risk procedure, no need for investigation, but if it is intermediate or high risk surgery, we need to arrange for ECG, biomarkers, and assess the functional capacity, and we are going later to discuss why do we need to assess the functional capacity in some patients. But if the patient is having established cardiovascular disease in low-risk surgery, no need for investigations. In intermediate risk, we need the ECG, biomarkers, and assessing function capacity. In case of high-risk surgery, we would add a cardiology consultation and multidisciplinary decision whether to proceed or postpone the surgery. If a patient with newly detected murmur and he is symptomatic for cardiovascular disease, so echo is class 1. If a patient has a newly detected murmur suggesting clinically significant pathology, it is also class 1 before high-risk surgeries. And in patient with a murmur and he is completely asymptomatic, echo is a class 2A before moderate risk surgery. So in general, we can say that unexplained audible murmur equals the need for transthoracic echocardiography. If the patient is having previously unknown angina and he is scheduled for elective surgery, in this case further diagnostic workup is needed before the surgery, but if scheduled for acute, emergent or urgent surgeries, in this case a multidisciplinary approach is recommended as soon as possible to choose the treatment with the lowest risk for the patient. In patients complaining of dyspnea or peripheral edema or both, of course, ECG and biomarkers including BNP or NT-proBNP are class 1 before the surgery unless there is a specific non-cardiac explanation, but if the biomarkers are elevated or not available, in this case we go for transthoracic echocardiography, of course. And please remember that the time delay when you perform unnecessary investigations may worsen the patient's prognosis due to delay in his necessary surgery. When we try to answer this question whether to avoid or allow surgery, which is usually answered by a multidisciplinary team, we need to put in our minds that the risk for a patient with acute surgical disease, if not operated on, is higher than the risk of the surgery itself. But an unstable cardiac patient should be stabilized before non-cardiac surgery, especially if it is elective surgery. And the high-risk non-cardiac surgery should be avoided in certain patients with life expectancy and quality of life taken into consideration, like in case of severe heart failure, NIHA class 4, cardiogenic shock, severe pulmonary hypertension, and severe frailty. But this decision should be made after discussions between the patients and relatives, surgeon, anesthesiologist, cardiologist, and geriatrician for elderly patients. So it is a difficult equation in order to choose between the surgery-related risk or leaving the patient without surgery, which may have a higher risk due to omitting the appropriate surgical procedures. So it is not an easy question to answer, avoid or allow surgery. And these are famous examples of the famous questions that the patients usually ask, like, do I need to take any cardioprotective medications before surgery? Who will inform my cardiologist? Do I need to stop or reduce any of my medications? Can my medications cause any problem during surgery or any contraindications with the drugs given during surgery? Who will take care of me and communicate any needs during my hospital stay? Can you give me please any information how I will be monitored before, during, and after surgery, and how will the healthcare professionals involved in my care be informed about my heart condition? After we finish the clinical risk evaluation, we are moving to some of the essential preoperative tools that we can use to assess this risk. They include the risk scores, functional capacity, ECG, biomarkers, and of course the non-invasive and in some cases invasive procedures. We can see here that they all measure the 30-day risk for morbidity and mortality regarding heart disease, and they don't use biomarkers as one of their variables. The most famous and classic score is the revised Cardiac Risk Index published in 1999 that assess coronary artery disease, stroke, heart failure, diabetes, CKD, and high-risk surgery. Each one of them is assigned 1 point. But the most recent one is the American University of Beirut Cardiovascular Risk Index published in 2019. It assesses 6 variables, which are 2H, history of heart disease and symptoms of heart disease, 2A, age more than or equal 75 years, anemia with hemoglobin less than 12, and finally 2S, vascular surgery and emergency surgery. Each one of them is assigned 1 point in order to assess the 30-day risk of death, MI, or stroke. Low risk from 0 to 1, intermediate risk from 2 to 3, and high risk from 4 to 6. But please remember that the task force decided that the selection criteria for further preoperative testing should be clinical criteria, not based on just specific score. So these scores are helpful, but you should not use them only without your clinical assessment and clinical sense. Regarding the functional capacity, which is an important assessment tool and we mentioned shortly in this video, in patients more than or equal 70 years scheduled for intermediate or high-risk surgery, frailty screening should be considered, like the clinical frailty scale, for example, and adjusting the risk assessment according to the self-reported ability to climb 2 flights of stairs should be considered also before intermediate or high-risk surgery, like measuring the METs by the treadmill test that we all do, and measuring the Duke Activity Status Index. Regarding the ECG and biomarkers, patients scheduled for intermediate or high-risk surgeries who have known cardiovascular disease, cardiovascular risk factors, or symptoms or signs suggestive of cardiovascular disease will need to have a preoperative 12-lead ECG, and in those patients we need to have high sensitivity cardiac troponin before, at 24 hours and 48 hours after surgery. So ECG once before surgery, troponin 3 times. Measuring BNP or NT-proBNP in the same categories of patients are class 2A. So troponins are usually preferred due to their advantages that they are more widely available, less expensive. If they are normal, they can rule out acute MI in the preceding days, and the availability of the quantitative assessment enables accurate diagnosis of perioperative MI on day 1 after surgeries. But of course, the BNP and the NT-proBNP have other advantage in detecting decompensated heart failure. The classic question: when do we need to have an echo before surgery? Echo has a class 1 recommendations in those with poor function capacity, depending on the Duke Activity Scale Index or the inability to climb 2 flights of stairs, patients with high level of biomarkers, detectable murmurs by auscultation, but before high-risk surgeries. So in this case, it is a class 1, and it is class 2A in patients with suspected new cardiovascular disease or unexplained signs or symptoms of cardiovascular disease, also before high-risk surgeries. The level of recommendation is down to class 2B in those with poor function capacity, abnormal ECG, high level of biomarkers, 1 or 4 clinical risk factors of those mentioned in the revised cardiac risk index, but before intermediate risk surgery. There is another alternative, which is the focus, which is a focused cardiac ultrasound exam performed by trained specialists or physiologists. It can be considered as an alternative to transthoracic echocardiography for preoperative triage, as here it is not time consuming and no need for delay. Is there any role for stress imaging before elective surgery? It has a class 1 recommendation before high risk elective non-cardiac surgery in patients with poor function capacity, high likelihood of coronary artery disease based on the pretest probability or presence of 2 or more risk factors, or high clinical risk according to the revised cardiac risk index. So the indication here is before high risk elective surgeries. And also it has a class 2A before high risk surgery in asymptomatic patient with poor function capacity, but they have history of previous PCI or CAPG. So all the indications for stress imaging is before high risk elective non-cardiac surgery, not before urgent surgeries. And if we speak about intermediate risk surgery, Here it has just a class 2B with controversy about its role, as here if the ischemia is of concern in those patients with clinical risk factors and poor function capacity, it may be performed, but there is no clear recommendations to perform them and delay surgery. And kindly note that the normal stress imaging exam, like for example pharmacological stress echo or myocardial perfusion, have high negative predictive value for postoperative cardiac complications. That's why they have strong recommendations in a specific situation when there is a risk for postoperative cardiac complications, and the exercise stress testing should only be considered as an alternative to diagnose coronary artery disease if non-invasive imaging testing are not available in the center. And we are not forgetting here the big no for some of the unnecessary investigations. Please don't perform a preoperative ECG or biomarkers level in low-risk patients undergoing low and intermediate risk procedure. No role for routine echo and no role for routine stress imaging before non-cardiac surgery. If one of your colleagues asked you that this patient is known to have ischemic heart disease, does he need a coronary angiography before his elective surgery? So far, the indications for invasive coronary angiography and revascularization in preoperative setting are the same as in non-surgical setting. So there is nothing called routine coronary angiography before surgery because this patient is known to have ischemic heart disease. That's why it is important, if there is an indication and a clear indication, in order to start treatment, either medical or intervention, if he is having ongoing ischemia. Sometimes we use coronary CT angiography in order to rule out coronary artery disease in patients with suspected chronic coronary syndrome, biomarker negative acute coronary syndrome, because if it is biomarker positive, we would need invasive coronary angiography in case of low to intermediate clinical likelihood of coronary artery disease, or patients unsuitable for non-invasive functional testing if they are undergoing non-urgent, intermediate, or high-risk surgery. Otherwise, it is not indicated. There may be a class 2B for preoperative coronary angiography in stable chronic coronary syndrome patients undergoing elective carotid endarterectomy, but no strong recommendation, and the big no, of course, for routine preoperative coronary angiography in stable cardiac patient undergoing low or intermediate risk surgery. So we have assessed the surgical risk and the patient-related risk in order to perform risk reduction before surgery. So we are moving now to the risk reduction strategies. Please advise your patient to stop smoking at least 4 weeks before their surgery to reduce post-operative complications, especially pulmonary and wound complication, and this is proven in randomized controlled trials. And advise the patient to have optimal control of the risk factors like hypertension, dyslipidemia, and diabetes before the surgery. The famous question, which medication to start before surgery? If a patient is already having an indication for statins, like for example dyslipidemia or atherosclerotic cardiovascular disease, so it should be considered to start them before surgery, and the best to start it at least 1 month before surgery. There is a class 2B, so there is a controversy about this issue, to start beta blockers before high-risk surgeries in those with 2 or more clinical risk factors according to the revised cardiac risk index, in order to reduce the incidence of preoperative MI or tachyarrhythmias at least 1 week before surgery, starting with a low dose and titration for a target heart rate of 60 to 70 beats per minute. And also it is a class 2B to start beta blockers before non-cardiac surgeries in those who have known coronary artery disease or myocardial ischemia, as they should be taking this medication already before surgery. But the big no is to start beta blockers routinely in any patient just to reduce the incidence of perioperative MI or tachyarrhythmias. There is no recommendation to do this practice. Then which medication to continue? We need to continue beta blockers and statins in those patients already receiving them. And regarding RAS blockers like ACE inhibitors, ARBs, or ARNI, patients with stable heart failure should continue on them, but this have a weaker recommendation of class 2B. And which medications to interrupt before surgeries? Patient without heart failure, they need to withhold RAS blockers on the day of surgery to prevent preoperative hypotension. Patients on diuretics for hypertension, they need to stop them on the day of surgery to reduce the risk of dehydration, hypovolemic shock, or any electrolyte imbalance. And patients taking SGLT2 inhibitors, they need to stop them at least 3 days before intermediate or high-risk surgery due to the risk of euglycemic DKA. And the final part in our video today is the perioperative monitoring and anesthesia. The perioperative monitoring includes the non-invasive measurement of blood pressure at regular intervals, but in hemodynamically unstable patients we may need invasive blood pressure monitoring, follow-up of the heart rate with closed ECG monitoring, pulse oximetry to measure the peripheral oxygen saturation, capnography to measure the end-tidal CO2, follow-ups of the urinary outputs, the degree of blood loss after surgery, and in specific situations we may need right heart catheterization to measure systemic vascular resistance, pulmonary capillary wedge pressure, and the stroke volume, but not in all situations. Regarding the perioperative monitoring, there is a class 1 to apply goal-directed hemodynamic therapies in those undergoing high-risk surgery, as assessing the stroke volume, response to fluid challenges, and the pulse pressure variation due to the high risk here for intraoperative hypotension, and this is usually performed in ICU or critical care units. It is recommended also to avoid postoperative acute pain in order to decrease the sympathetic drive and shorten the recovery time, and that's why there is a role for neuroaxial analgesia to control the pain. And there's also a class 1 to avoid an intraoperative hypotension, which is a decrease in the mean arterial pressure more than 20% from the baseline, or drop of blood pressure to less than 60 or 70 mm mercury for more than or equal 10 minutes to minimize the risk of postoperative organ dysfunction like acute myocardial injury, acute kidney injury, or cerebrovascular stroke. There are no clear recommendations according which type of anesthesia to use. That's why we need to have a multidisciplinary discussion between the cardiologist, surgeon, and anesthesiologist to choose the appropriate mode of anesthesia for the patient according to the risk profile of the surgery and of the patient. But there is a big no to avoid using non-steroidal anti-inflammatory drugs for postoperative pain in those with established or high risk of cardiovascular disease due to the risk of perioperative MI and risk of salt and water retention that may precipitate acute heart failure, especially with COX-2 inhibitors. I know that you are exhausted now, of course, so after this long video in which we tried to give a resume of the preoperative assessment, testing, and how to reduce the risk of surgery in general, I know it may seem to be a complicated approach, but if you put some rules in your mind based on the evidence from literature and guidelines and try to stick to them after assessing your patient meticulously, in this case it becomes straightforward, and you need to discuss your opinion with the other team members, including the surgeon, anesthesiologist, geriatrician, and of course the patient, who would be the first one to take the decision whether to proceed or not. And we are going to have more specific videos regarding specific disease, regarding the antithrombotic medications and how to deal with them before surgery. Thank you very much for watching this video, and wait next week for another topic related to preoperative assessments.